HCC treatment with medication, immunotherapy, and targeted drugs. When liver cancer advances beyond surgical options, modern medicine offers targeted treatments that can extend life and maintain quality of life. This video breaks down the medications available for advanced hepatocellular carcinoma, liver cancer that has spread or cannot be removed surgically, including immunotherapy combinations, targeted drugs, and how doctors select the right therapy for each patient. This evidence-based content is professionally sourced by Saboor, consultant surgeon. Hepatocellular carcinoma typically develops in patients with chronic liver disease and cirrhosis. Advanced HCC refers to cancer that is spread beyond the liver, involves major blood vessels, or is too extensive for surgery or local treatments. Systemic therapy. Medications that travel through the bloodstream to reach cancer cells throughout the body has transformed outcomes for these patients. Unlike traditional chemotherapy, today's treatments include immunotherapy, which harnesses the immune system, and tyrosine kinase inhibitors, drugs that block specific proteins cancer cells need to grow. What makes treatment selection complex is that most HCC patients have both cancer and underlying liver dysfunction, requiring doctors to balance tumor control against liver preservation. Before we dive deeper, let's establish what we're dealing with. Treatment eligibility depends on two critical factors. First, liver function assessed by the Child-Pugh classification, a scoring system measuring albumin, bilirubin, clotting ability, fluid accumulation, and brain function. Second, performance status, how well patients can perform daily activities. For most patients with Child-Pugh Class A liver function, meaning relatively preserved liver capacity with scores of 5 to 6 points, and good performance status, immunotherapy combinations now represent preferred initial treatment. Atezolizumab plus bevacizumab is one such regimen. Atezolizumab is a programmed cell death ligand 1 inhibitor. It blocks a protein cancer cells use to hide from the immune system, while bevacizumab is a vascular endothelial growth factor receptor inhibitor that cuts off the blood supply tumors need to grow. In a phase 3 trial called IM-BRAVE 150, this combination improved overall survival compared with sorafenib, an older standard treatment. The median overall survival, the point at which half of patients were still alive, reached 19.2 months with atezolizumab plus bevacizumab versus 13.4 months with sorafenib alone. But here is the critical detail. Patients receiving bevacizumab must undergo esophageal varices evaluation, screening for enlarged veins in the swallowing tube, within 6 months before treatment, because bevacizumab increases bleeding risk. Tremelimumab plus durvalumab, also known as the STRIDE regimen, offers another first-line immunotherapy option. This combination pairs a cytotoxic T lymphocyte-associated protein 4 inhibitor with a programmed cell death ligand 1 inhibitor, attacking cancer through 2 immune pathways simultaneously. The Himalaya trial demonstrated that tremelimumab plus durvalumab improved overall survival over sorafenib while maintaining tolerability. This regimen is particularly favored for patients with minimal disease burden because of convenient dosing, just 1 dose of tremelimumab followed by ongoing durvalumab, and favorable side effect profiles. When immunotherapy combinations are not suitable, tyrosine kinase inhibitors provide effective alternatives. Lenvatinib is preferred over sorafenib for initial therapy. In the REFLECT trial involving 954 patients, lenvatinib demonstrated non-inferior overall survival to sorafenib, median 13.6 versus 12.3 months, but achieved superior response rates and delayed tumor progression. Importantly, lenvatinib proved better tolerated, with less hand-foot skin reaction, painful redness and peeling of palms and soles, less hair loss, and less fatigue compared with sorafenib. The typical starting dose is 12 mg once daily for patients weighing 60 kg or more, or 8 mg for lighter individuals. However, patients with tumor involving more than 50% of liver volume or main portal vein invasion were excluded from trials, limiting evidence in very advanced disease. Sorafenib, the first approved systemic therapy for HCC, remains an option when lenvatinib is unavailable or not tolerated. This multi-targeted anti-angiogenic tyrosine kinase inhibitor blocks multiple proteins cancer cells use for growth and blood vessel formation. For patients whose cancer progresses despite first-line treatment, multiple second-line options exist, though selection depends on what they received initially. After immunotherapy-containing regimens fail, observational studies support using lenvatinib as second-line therapy. One study of 233 patients who progressed on atezolizumab plus bevacizumab found median overall survival of 17 months with second-line lenvatinib, compared with 14 months for sorafenib and 12 months for cabozantinib. Regorafenib is specifically indicated for patients who tolerated but progressed on sorafenib or lenvatinib. In the RESORCE trial, patients who had received sorafenib for at least 3 weeks and tolerated 400 mg or more daily lived a median of 10.6 months with regorafenib versus 7.8 months with placebo. This 3-month improvement represents meaningful time for patients with advanced cancer, though it underscores how challenging HCC treatment remains. Cabozantinib offers another second-line choice for patients with Child-Pugh Class A cirrhosis. The Celestial trial demonstrated median overall survival of 10.2 months with cabozantinib versus 8 months with placebo among patients previously treated with sorafenib. The most common severe side effects included palmar-plantar erythrodysesthesia, that same hand-foot reaction in 17%, high blood pressure in 16%, and elevated liver enzymes in 12%. Pembrolizumab, a programmed cell death protein 1 inhibitor, gained approval for second-line treatment, specifically in patients with hepatitis B-related HCC who received prior non-immunotherapy systemic treatment. In the Keynote 394 trial conducted in Asian patients, pembrolizumab improved median overall survival to 15 months versus 13 months with placebo, a modest but statistically significant benefit. The objective response rate, meaning measurable tumor shrinkage, was 13% with pembrolizumab versus only 1% with placebo, including complete responses in 2% of patients. The Child-Pugh classification is fundamental to treatment selection because medications are metabolized by the liver, and most patients have compromised hepatic function. Child-Pugh Class A scores 5 to 6, indicates well-compensated cirrhosis, meaning liver function for practical purposes is near normal. These patients are eligible for all systemic therapies discussed. Child-Pugh Class B scores 7 to 9, reflects moderate liver dysfunction, with features like low albumin below 2.8 grams per deciliter, bilirubin elevated above 3 milligrams per deciliter, or ascites requiring diuretics. For these patients, single-agent immunotherapies such as durvalumab or atezolizumab represents reasonable options, though effectiveness is reduced compared with Child-Pugh A patients. The pooled objective response rate for single-agent immunotherapy in Child-Pugh B disease was just 12% versus higher rates and better liver function. Child-Pugh Class C scores 10 to 15, indicates decompensated cirrhosis with severe dysfunction. Most patients with Class C liver function have insufficient hepatic reserve to tolerate systemic therapy, and their limited overall survival from liver disease alone means cancer treatment is unlikely to provide meaningful benefit. Supportive care focused on symptom management and quality of life is most appropriate for these individuals. For patients whose HCC recurs after liver transplantation, treatment options are restricted. Immunotherapy-containing regimens are contraindicated, absolutely not offered, because stimulating the immune system can trigger organ rejection. Allograft rejection rates may reach 39% in transplant recipients who receive immune checkpoint inhibitors, potentially causing loss of the transplanted liver. Therefore, anti-angiogenic tyrosine kinase inhibitors, specifically lenvatinib or sorafenib, represent the initial therapy for post-transplant recurrence. These medications are effective and feasible to administer alongside immunosuppressive therapy, such as mammalian target of rapamycin inhibitors or calcineurin inhibitors that transplant patients require. Any patient interested in immunotherapy post-transplant should only receive it within a clinical trial with transplant hepatology support, given the substantial rejection risk. Evaluating whether treatment is working requires specialized imaging criteria because HCC responds differently than solid tumors in other organs. For patients receiving tyrosine kinase inhibitors or other targeted agents, modified response evaluation criteria in solid tumors for HCC, or MRECIST, is used rather than standard RECIST. These criteria measure tumor viability, living cancer tissue, rather than just size, because targeted therapies often cause tumor necrosis or tissue death without immediate shrinkage. Complete response means disappearance of all arterial enhancement within tumors on CT or MRI scans. Partial response requires at least 30% decrease in the sum of viable tumor diameters. Progressive disease is defined as at least 20% increase in viable tumor diameters or appearance of new lesions. For immunotherapy, response patterns differ from targeted agents. Immune-related response criteria account for phenomena like pseudoprogression, temporary apparent tumor growth before eventual shrinkage, as immune cells infiltrate cancer. If you or someone you love has been diagnosed with advanced hepatocellular carcinoma, request multidisciplinary evaluation at a specialized center with hepatology, medical oncology, interventional radiology, and transplant expertise. Not all hospitals have equal capabilities for HCC management, and outcomes demonstrably improve at centers offering comprehensive treatment options. Ensure hepatitis B and hepatitis C testing has been completed, because viral reactivation can occur during systemic therapy and requires preventative antiviral treatment. For hepatitis B carriers or those with past infection, antiviral prophylaxis may be mandatory before starting immunotherapy or targeted therapy. If bevacizumab-containing treatment is planned, you need esophageal varices screening with upper endoscopy, a camera scope examining the swallowing tube and stomach within the past 6 months. Varices are enlarged veins that can bleed catastrophically when bevacizumab is given, so they must be identified and treated first with rubber band ligation or medication. What is my Child-Pugh classification and performance status, and how do these affect my treatment options? This fundamental question determines eligibility for different therapies. Am I a candidate for first-line immunotherapy combination, or would tyrosine kinase inhibitor monotherapy be more appropriate for my situation? Understanding the rationale helps you participate in decision-making. What side effects should I monitor for with my specific regimen, and when do they require urgent medical attention? Hand-foot syndrome, high blood pressure, bleeding, liver enzyme elevations, immune-related inflammation, and diarrhea all require different management strategies. Contact your oncology team immediately for fever above 38 degrees Celsius or 100.4 Fahrenheit, which could indicate infection when immune function is altered. Seek urgent care for new or worsening yellowing of skin or eyes, suggesting liver function deterioration or bile duct obstruction. Vomiting blood or black tarry stools requires emergency evaluation for gastrointestinal bleeding, especially if you are receiving bevacizumab. Severe abdominal pain, confusion, difficulty breathing, or chest pain also warrant immediate assessment, as these may represent serious treatment complications or disease progression requiring intervention. Expect blood tests including complete blood count, comprehensive metabolic panel with liver enzymes, and tumor markers every 2 to 3 weeks initially, then monthly once stable. Cross-sectional imaging with CT or MRI of chest, abdomen, and pelvis occurs after 6 to 8 weeks on treatment to assess response, then every 2 to 3 months throughout therapy. For patients with hepatitis B, HBV DNA levels require monitoring to detect viral reactivation early. These monitoring schedules may intensify if side effects develop or liver function deteriorates. Advanced hepatocellular carcinoma treatment has evolved dramatically, with immunotherapy combinations now standard first-line therapy for appropriate candidates, tyrosine kinase inhibitors providing alternatives and second-line options, and treatment selection guided by liver function classification. Post-transplant patients require anti-angiogenic agents only, avoiding immune checkpoint inhibitors entirely. Specialized response criteria account for unique treatment effects. Multidisciplinary expert care optimizes outcomes in this challenging disease. This information is for education. Always discuss your individual situation with your healthcare provider. The American Association for the Study of Liver Diseases provides clinical practice guidelines on HCC management at www.aasld.org, offering evidence-based recommendations updated regularly. The European Association for the Study of the Liver publishes comprehensive HCC clinical practice guidelines at www.easel.eu with detailed treatment algorithms. For patients and families, the American Liver Foundation offers educational materials and support resources at www.liverfoundation.org, explaining HCC in accessible language. Thank you for watching this video.